Should we start?
Yes, please. Let's start.
So, presenting the case of a 45-year-old married Muslim patient who is a housewife by occupation from Kunia, Punch, who presented to us with chief complaints of shortness of breath for 10 days, cough for 9 days, and fever on and off since 9 days. So moving on to history of present illness. Patient was apparently all right 10 days back when she started with shortness of breath. It was acute in onset, progressively increased over the course of days. The grade of her breathlessness increased along the course of her illness. Initially, patient was able to do her normal activities and was breathless only on exertion or climbing upstairs or hurrying on level ground. But now patient complained of breathlessness even at rest. Patient described her symptoms as chest tightness, inability to take deep breath, and audible wheeze. There is no history of chest pain, palpitations, increase in severity on lying down or nocturnal awakening, or sleep disturbance. There was no relieving factor except a medication she took at a local hospital. Patient also complained of dry cough for 9 days. It was not associated with sputum production. There was no diurnal variation or change in severity of cough. There is no postural variation with severity of cough, and there was no significant aggravating or relieving factor as per history. There is no previous history of seasonal variation of cough or history of allergy, or no. There is also no history of exposure to dust or pollen or allergy to both of them. Sir, patient also complained of feverish sensations for 9 days. It was not documented. It was not associated with rigors or chills. There is no history of evening rise of temperature or profuse sweating. There is history of patients. Patient only had a history of COVID infection in 2021, which was a mild illness, which did not require hospitalization. And general currently patient has, in addition to her these three complaints, she had anorexia and malaise and myalgias. There is also contact with cattle, and patient is still using chula for cooking. Sorry. So, patient has no history of sore throat, hoarseness, stridor, odynophagia, loss of consciousness, or decreased sensorium or bluish discoloration, hemoptysis, and or weight loss. There is no history of acid reflux, regurgitation, or vomiting. Patient also has no history of allergy to dust, dander, or smoke. There is no history of travel outside, chest pain, palpitations, swelling of feet, frothy urine, decreased urine output, bleeding from any side. There were no connective tissue disease features, sir. Sir, there is also history of COVID infection in 2021, which was a mild illness that did not require any hospitalization or oxygen support. There is no history of similar illness in past, and there is no history of ATT intake. There is no significant medical history in family. Patient did not give any history of hypertension, type 2 diabetes, hypothyroid, ATT intake, or COVID. There was just COVID infection of her mother-in-law with whom she was in contact during 2021. So in personal history, patient has a mixed diet, adequate sleep, appetite, and normal bowel and bladder. She is not addicted to any drug, neither alcoholic nor smoker. So she is LP P4 in menstrual and obstetric history, has regular cycles which recur after 28 days and last for 4 days. There is no known drug allergy. In summary, patient is a 45-year-old married female with no previous comorbidities, presenting with 10-day history of fever, non-productive cough, and shortness of breath, which increased from grade 2 to grade 4 MMRC without any history of orthopnea, PND, chest pain, or any with only previous history of mild COVID illnesses 2021, sir.
Okay. Nice. Good job, Shamshul. Presented your history well. So just a few points, like you have mentioned in your summary also. So if this lady who's a middle-aged lady, she has presented with the, I think in the chief complaints, the first symptom to start was
Sir,
breathlessness, right?
yes, sir.
So that's a little striking. because if the history is accurate, if what she remembers and is telling you is correct, is exactly how it happened. Breathlessness first, followed by cough, and then fever, that too feverish sensation. So the order is a little surprising. In any case, let us consider that this is what happened. Uh, let if a patient has breathlessness before cough, the order is usually it's significant in terms of giving you some clue. So can you tell me, if one patient has first breathlessness then cough, whereas another patient has cough first and then breathlessness, what can you make out of these two histories?
Sir, usually if a patient presents to us with cough with fever before breathlessness, then most likely we are dealing with a respiratory case, likely an infective pathology.
Excellent, correct. Whereas if the breathlessness starts first and then followed by cough.
Sir, most likely, less likely it is a respiratory, and most likely it might be some cardiac, like
Excellent,
or
excellent.
non-respiratory.
Perfect. So, in when you are trying to distinguish between whether the pathology is regarding or related to respiratory system versus related to cardiovascular system, one of the points is if the patient has both these symptoms, cough and breathlessness, how is the order? Which came first? Which came later? As you correctly pointed out, if the breathlessness starts first and then later followed by cough, especially pink frothy sputum, that kind of cough, then it favors a cardiovascular system diagnosis.
Yes, sir.
Whereas if the cough starts first and later on is followed by breathlessness, favors a respiratory system diagnosis. Then there are other ways to distinguish, like for example, history of palpitation, history of syncope. These would favor cardiovascular system. Correct? So in your case, clearly the patient remembers that 10 days ago the breathlessness started first. I mean, breathlessness started and then followed by 9 days ago where the cough started. So there was a 1 day gap clearly. So that's a slightly um, unusual presentation, but we can't say it cannot happen. One very important clue is when you say sudden onset breathlessness, correct? The patient gave history that the breathlessness was sudden in onset. So can you tell me some causes of sudden onset breathlessness?
So, sudden onset breathlessness in a patient who is apparently all right previously. First of all, we should think of more sinister causes like pulmonary thromboembolism.
Very good.
So then we can say we should rule out MI like illness, which
Correct.
has.
Very true. Correct.
Yes, sir. And then usually, sir, sudden breathlessness is not unlikely of a chronic respiratory problem. It gives a bit
Okay. But what
more.
can cause? So if somebody is presented to you with sudden onset breathlessness, just started and they would just come to you within a few hours of the breathlessness starting.
Sir, and we can also think of pneumothorax. Sir.
Very good.
Sir.
Pneumothorax. Excellent. Excellent. So pulmonary embolism, you have to keep in mind. Pneumothorax also an important cause among the respiratory. Cardiovascular system, myocardial infarction. It could be an arrhythmia. So there's something
Yes,
called
sir.
flash pulmonary edema. If
Yes, sir. Flash pulmonary edema in patients who are predisposed, like CKD patients, we have like
correct,
they usually present like that.
correct. So especially if the blood pressure spike all of a
Yes,
sudden, example in renal artery stenosis,
yes,
that can precipitate pulmonary edema. So any cause of flash pulmonary edema, myocardial infarction, as you
yes, sir.
said, can cause flash pulmonary edema, or it could be an acute mitral regurgitation, acute aortic regurgitation,
Second, yes, sir.
whether because of MI or whether because of infective endocarditis. So some things that's happened suddenly, or it could be an arrhythmia also. Like for example,
Yes, sir.
atrial fibrillation, paroxysmal atrial fibrillation,
Yes, sir.
suddenly starts can cause sudden onset breathlessness also, if it is
Yes,
enough
sir.
to precipitate heart failure. Those are cardiovascular causes. In terms of respiratory, one more you could point out is if there is an asthma. So even if the
Yes,
patient
sir.
didn't have a previous episode, this could be an index episode, or it need not have to be an atopy related asthma. It sometimes there's something called RADS, reactive airway dysfunction syndrome.
Yes, sir.
So even inhalation of certain volatile compounds can suddenly trigger bronchoconstriction and breathlessness, even in a non-asthmatic individual.
Yes, sir.
Correctly pointed out. So one thing you should keep in mind, especially if this breathlessness precedes cough, is a diagnosis of pulmonary embolism also. Of course, 10-day history is quite long,
Yes, sir.
but still. one thing that can still be kept in mind. I like the fact that in your history of presenting illness, you have described the breathlessness for related to her activities.
Yes, sir.
And then in the summary, you have mentioned the grade according to MMRC, which is correct, which is good. But we didn't get many clues in terms of variation, right? There was no variation for the
Yes, sir.
breathlessness with
No.
posture nor diurnal. So we didn't get too many clues there, though it is
Yes.
there at rest, but no orthopnea, no variation. So can you name some postural variation of breathlessness or certain terminologies and causes related to that?
Yes, sir. Sir, patient who has a cardiac origin breathlessness, usually secondary to acute decompensated heart failure, those patients usually present with they will give a history of orthopnea while lying down. Their breathlessness will increase. Also,
Correct.
these patients, while they sleep, they can have a history of frequent awakening at night. They might not say that typical uh, picture that we get in this PND, but they may say that they have this sleep disturbance for which they have to sit upright and then sleep. And then, sir, we can have in even in pulmonary disorders, we have like patients who have infection in who are comatose or immunocompromised patients with involvement of right lung. They might have or either lung on lying down or that side they may have difficulty in breathing or
Correct. Correct. So even if a patient has a lung abscess, so they
yes,
may, let's say there's a unilateral lung abscess, they would have certain amount of breathlessness if they lie on the opposite side as the lung abscess
yes,
drains into the bronchus. It might trigger cough and breathlessness. In a unilateral massive pleural effusion, they may prefer to lie on the side of the effusion because
yes,
lying on the opposite side will compress the normal lung. So that is called trepopnea. If the breathlessness is aggravated on a particular lateral decubitus, it's called trepopnea. Orthopnea, like you said, very correct, when the breathlessness worsens on lying down and improves on sitting up. And of course, there are others like platypnea is the opposite of orthopnea. Any causes of platypnea you can name?
so usually in patients of mm,
No problem. No problem.
I
So,
cannot
any people in
remember now.
hepatopulmonary syndrome. So, hepatopulmonary syndrome is a late complication of chronic
Cirrhosis.
cirrhosis,
Yes, sir.
myxoma or left atrial ball valve uh, when the breath
Bending
occurs.
forwards.
So these are all terminal, but precedes orthopnea. Orthopnea is a slightly more
No, sir.
delayed manifestation of postural breathlessness, something that happens little earlier. Typical episode.
Sir, one they can say that they have their cough aggravates on lying down while their progression from just like this patient had progression from grade 2 to grade 4 breathlessness. In that progression, those patients can say that they can use those the minimal clues to their illness, like they can say while they are asleep there is a slight disturbance in sleep or
Correct. So if
they
it happens suddenly in the middle of their sleep, what is that called? When
sir,
they are asleep?
sir, paroxysmal nocturnal.
Very good. So
Yes,
a history of PND may precede orthopnea. Orthopnea is
yes,
a little more advanced when they're just not able to lie down at all. But
sir.
whereas in PND, a slightly earlier stage of heart failure, left ventricular failure, they may be able to go to sleep, but they wake up with breathlessness and cough and sort of air hunger where they are
Yes,
trying to take in as much oxygen as possible. They may go to they'll put their legs by the side of the bed, they'll be coughing pink frothy sputum and still not enough. So they'll go to the window, open the window and try and take in as much air as possible. By then the PND will correct.
yes.
Okay, good. Otherwise, after one day, the cough started. So patient with breathlessness and dry cough, what will you think of? Dry cough, no? Patient has.
Breathlessness and dry cough only without fever, we will first think of cardiac causes, sir. We can think of
Okay.
cardiac causes, we can think of obstructive airway disease that has precipitated
Yes,
as
yes,
an
very good.
excess.
Correct, correct,
Or we can just say that this is an index event, just like you correctly said that it could be an event of an obstructive airway disease that has not been previously diagnosed, like adult onset asthma or hyperreactive airway disease that has presented like that.
correct, correct. So if you are thinking of a lung pathology producing breathlessness, generally you expect extensive involvement, bilateral
Yes,
lung
sir.
involvement, or one entire lung totally gone, and in a
Yes, sir.
very acute setting, then you can expect breathlessness in lung diseases. Otherwise, it's usually it takes some time for breathlessness to manifest. Usually there'll be cough, usually maybe even chest pain before the manifestation of breathlessness. Otherwise, if you're not talking about the duration or you're not taking time into the equation, patient with breathlessness and cough, dry cough, you can think of a pleural pathology also, because pleural diseases should not
Yes.
produce productive cough.
Yes, sir.
Or you could think of interstitial pathologies.
Interstitial. Yes, sir.
So, interstitial, if you're thinking now, if you bring in the time factor, acute interstitial disease, you should think of atypical pneumonias. So, pneumonias
Yes,
which don't
exactly.
involve the parenchyma and don't produce consolidation like a typical pneumonia,
Pneumonia.
atypical pneumonias. So, that
We,
also is a differential. If you think of an acute dry cough with breathlessness, generally the cough should have preceded breathlessness.
yes,
But
sir. But maybe patient was.
yeah, finally, that's true. Recollection may not be strong.
Yes, sir.
Sometimes they would have had the symptom and they would have persisted. Everybody has to get on with their lives. So
Yes, sir.
they will try and bear the symptoms. They'll not
Yes, sir.
try and let it bother them till it comes to a stage where it's
Yes,
just
sir.
not possible. So maybe she had the symptoms. She's not able to recollect properly. So you can also like little bit more, you can dig into the history and ask
Yes,
her,
sir.
uh, try and remember, did you have the cough even before? If they are able to admit it, then okay. Otherwise, of course, we still have to consider that yes, this is what is truly the history. This is what happened. So she had the breathlessness first, dry cough after that, and then the fever. Now, are you sure? Are you convinced that the patient had fever?
Sir, at the time of admission, patient had no, we had
Okay.
documented 100 degrees Fahrenheit fever, and she was
Okay.
febrile to touch. But after that, once we started treatment, there was no documentation of fever.
That's
Furthermore,
okay. I mean, this is on examination, but on history, do you
but
think?
on
Are you convinced that she had fever? So there
sir,
was no documentation. They're not
yes, sir.
educated, they may not document, or they may not have a thermometer
Yes,
to check
ma'am.
themselves.
Yes,
They
sir.
she didn't keep your history mentioned there's no chills and rigors. That would have been an important point. If she complained of chills and rigors, very
Then
much in
yes,
favor
sir.
of history wise, very much in favor of fever being there. Anything else you can ask if you're in doubt whether the patient really had fever or not. Because 9, 10 days of a lung. So right now we are localizing to the lung, right? Because
Yes,
of
sir.
cough, breathlessness, and fever. One of the main localizations right now is in the lung, especially wheezing history. We didn't discuss that. You said she also had a wheeze. She
Yes, sir.
described chest tightness and wheeze. So we are localizing towards the lung. So 9 to 10 day of fever or an infection in the lung is quite prolonged. So you always want to make sure whether it's an infective, whether it's non-infective cause of the pathology. So fever would be important. So one history, chills and rigors. What else can you ask when you're in doubt? You ask them if they have been taking paracetamol or have they
Yes,
taken a
sir.
medicine to try and relieve their breathlessness.
But
So sometimes it can be a little more subjective also. Sometimes the patient may feel feverish, but they wouldn't have a fever.
yeah.
They might just be feeling a little fatigued or weak and they feel they are having fever. But if they are feeling that they have a fever, they will take a paracetamol. Everybody knows this by now.
Yes, sir.
In this day and age, everybody goes
Yes,
to
sir.
the pharmacy over the counter, take a paracetamol to try and relieve their symptom and get on with their lives. But when a patient has fever and they take paracetamol, you expect the patient to have sweating. So you can ask them, did you take paracetamol? How many paracetamol tablets were you requiring each day? And whenever you took the paracetamol, little while later, did you have sweating?
Yes,
If they
sir.
give this history, if they say, yes, this is what happened whenever I took paracetamol, I used to have sweating, then that goes very much in favor of the patient having actual fever.
Fever.
Otherwise, if they were feverish and but they didn't bother taking a paracetamol, or even after taking paracetamol, they never had the sweating, then you start doubting whether the patient had feverishness, because somebody who's having breathlessness, somebody who's having this kind of cough may feel fatigued and feel that is fever.
Yes, sir.
So history wise, one of the few of the questions you can ask to try and find out really whether the patient had fever or not is whether they took paracetamol and did that cause sweating after taking, as well as chills and Riga history, which you asked. So let's say the patient did have fever. Now fever, dry cough, and breathlessness with wheezing. So as you have summarized here also in this slide,
Yes, sir.
these symptoms, I think wheezing is something you should have added here. You're not added. Without history of chest pain, that is important. Chest pain, how would it have helped if the patient did complain
Sir,
of chest pain?
sir, chest pain palpitations would have localized our pathology to cardiac, something related to.
Though that is correct, if it is anginal type of chest pain, it would have favored cardiovascular.
Yes, sir.
But there is some cause of respiratory cause of chest pain.
Yes, sir. Pleuritic chest pain could have
Correct.
been.
So how will you distinguish what is the characteristic of pleural type of chest pain?
So, usually it is sharp stabbing kind of chest pain, and patient usually points to it and keeps a hand at that.
Correct. So site is also important. Usually angina is retrosternal
Yes, sir.
and it may not even be described as pain.
And patient usually holds his breath while this
For
inhaling.
pleuritic, you mean?
Yes, pleuritic.
Yeah, pleuritic pain, they're scared to take a breath in.
Yes,
So
sir.
every time they breathe also. And so site is important. Retrosternal for angina, lower lateral aspect of chest wall for pleural type of chest pain.
Yes, sir.
Aggravated with coughing, aggravated with deep inspiration. Correct. So these are few points which would favor pleuritic type of chest pain. So even pneumonia or a consolidation can result in a synpneumonic effusion. Before the effusion, there can be some pleuritic type of chest pain. So that would have been important if you're thinking of a respiratory localization for the symptoms. So at this point, with this much of this summary, what are you thinking of differential diagnosis?
Most likely, keeping everything in mind, it is the system that is most likely involved appears to be lungs, and there is, I think, involvement of lung parenchyma with secondary involvement of bronchi, sir, because patient has wheeze.
All that is okay. No, you
Uh,
you aim your
etiology,
arrow on the center of the bullseye. The
okay,
patient
sir.
wants a diagnosis. I have come with these symptoms. Tell me what I
And
have.
most likely it is an infective pathology
Okay.
affecting her lungs. Most likely, this might be pneumonia. We
Good.
have a strong possibility of atypical infection in this patient.
Very good. So so you're saying atypical pneumonia.
Yes, sir.
Correct. So what are the points favoring this diagnosis just at the history level? What are the points favoring atypical pneumonia in this lady?
So, first is her symptoms like uh, fever, this dyspnea, and cough, dry cough, especially dry cough, and
Correct. Dry cough is very, very important because productive cough with breathlessness you can expect in typical pneumonia.
typical.
Short history you expect with a typical organism.
Yes, sir.
Whereas a prolonged history, dry cough with breathlessness, you would more think of atypical
Atypical.
organisms.
Yes, sir.
Correct.
And also further, sir, there is history of those myalgias and other things, so most likely we are dealing with that thing only.
Correct.
uh,
Good. You have also mentioned there was an interesting observation in your history that there is exposure to cattle.
yes,
What
sir.
what importance would you give that?
So there are some lung infections which can be which are usually transferred from cattle, like zoonosis, like we have brucella, but brucella would not present like an acute illness.
Correct. Lungs, brucella, not very common.
So chlamydial infections like chlamydia, but usually there we have this uh, uh,
Chlamydia, okay. I mean, again, not the best. So sometimes the patient may just have fever and continue to have fever, and then you'll be asking Q, Q. Patient is also asking Q, Q. You are also asking Q, Q. So the answer may be it's a Q fever.
Q
So what
fever.
causes Q fever?
Yes.
It is
Q.
Coxiella burnetii. So cattle
Burnetii.
exposure
Coxiella.
could also be related to Q fever. That can also be an agent that produces atypical pneumonia or culture negative infective endocarditis. So anyone with prolonged fevers without like typical presentation, not exactly consolidation, not exactly localized to one part,
Sure.
it can be due to Q fever also. You have to keep that as a differential because that history of cattle exposure is there. Um, so most of these atypical pneumonias, they're called walking pneumonias. They need not present with the florid picture, acute progression that you see in patients with proper typical pneumonia. One thing I would have liked more from you is when you're putting these grades, no, grade 2 to grade 4, or when you're describing it in HOPI, the timeline, if it was more exact, it would have been better. For example, initial breathlessness on doing her work or climbing upstairs, you had mentioned those. If those were there for the first 3 4 days, by the fifth day she became
Okay.
breathlessness even at rest, like that. So how soon
Okay.
did it progress? That would have been an important point. For example, if her breathlessness on climbing steps was there for the first 8 days or 9 days, and only since one day she's become breathless at rest, so that would have told us, okay, the disease been progressing slowly, and now it's reached MMRC 4 versus something that reached MMRC 4 even on the second or third day. Then we would have had to know what she did, because you have mentioned she took some medications. It was relieved.
Yes.
Breathlessness was relieved with some medicines. So
Yes.
what may have been given? Did you make an attempt to ask what kind of medicines were given? Were they
Sir,
injectables? Were they
sir, she did not remember it clearly. So I
okay?
tried.
Generally, they'll remember if was it a nebulization? Was she given?
Nebulization. I had asked. I tried to ask that, but she didn't give that history.
She
So
didn't say it was
uh,
because she could hear the wheeze. She's given that history that she could hear the wheeze. So maybe either an injection or maybe
yes,
some
sir. Most they
medicines.
were. She said that she had been given some injection. I think most likely that could have been some steroid or something. Bec-
Possible, possible. Okay. Nonetheless, if that timeline, you can still be a little more precise. You can ask.
okay.
Of course, finally, if the patient can't remember, if she remembers 10 days, 10 days is not very long. She should be able to still tell that up till 4 or 5 days she was having MMRC
Yes,
grade
sir.
2, and then since 3 days it's become MMRC 4. That would have completed your breathlessness history. Okay, so for the time being, we have to proceed with this much in our mind. Our main suspicion is, since she doesn't have any previous comorbidities,
No, sir.
that she this may be like an atypical pneumonia, and that has produced breathlessness. From here, let's move on to examination.
Moving on to examination. Patient is conscious, cooperative, obeying commands, well oriented to time, place, person, staying comfortably in bed. Sir, vitals BP 120 by 80 in left arm and 128 by 84 in right arm, measured in sting position. And patient had pulse rate of 86, which was regular, good volume, normal character with no radioradial, radiofemoral delays, and all peripheral pulses were felt equally. Patient had a saturation of 96 on nasal bronchs at 3 liters oxygen, and respiratory rate was 18, and temperature of patient was 98 degree Fahrenheit. JVP was not elevated, and BMI 22.5, height 165 centimeter, and weight of 64 kgs. So, in general physical examination, there was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Hairline was normal. Eyes, there was no redness or discharge from eyes. Pupils were equal and responsive to light bilaterally. And oral cavity hygiene in oral cavity was satisfactory. There was normal dentition, no dentures. Skin was normal grossly. Nails were normal. Hands, no clubbing and no nicotine staining. Sir, feet, there was no neither clubbing, and nails were normal. So on respiratory examination, inspection, trachea appeared central, no prominence of sternocleidomastoid on either side. The respiratory rate was 18 per minute. It was thoracoabdominal, No visible veins, pulsations, or draining sinuses seen. Accessory use of muscle was not seen. Point of maximal impulse was not visualized on inspection. Skin was grossly normal with no visible swellings, pulsations, discharging sinuses. Shape of chest was elliptical with no visible deformity and nipples were at same level. There was no fullness or retraction of intercostal spaces. However, on inspection, audible wheeze could be heard, sir. So on inspection of spine, it was normal. There was no deformity of spine. Scapulae were symmetric. No drooping of shoulders, no winging of scapula, no abnormal venous prominence. Respiratory movements on inspection were equal and symmetric bilaterally. Upper anterior, upper posterior regions of both left and right side moved equally and symmetrically. Movements were a bit restricted in lower anterior and lower posterior regions of right side. So on palpation, findings of inspection were confirmed. There was the trachea was central, spine normal with no tenderness. Apex beat was in fifth intercostal space, just medial to mid clavicular line, tapping in character, located within one intercostal space and not beyond that. There was no thrill or heave. Temperature was normal in all areas. There was no bony or intercostal tenderness, no crepitation felt. So respiratory movements on palpation were felt equal in supraclavicular areas bilaterally. They were equal in right and left memory area, and there was slight limitation on in right infrascapular area. Dimensions. Transverse diameter of chest was 33, anterior-posterior diameter 18 centimeter, giving a ratio of 0.5 anterior-posterior to transverse ratio, and chest circumference was 84 centimeter on inspiration, and on expiration it was 81 centimeter. Right hemithorax was 40 centimeters on inspiration and 41.5 centimeters during expiration. Left hemithorax was 41 centimeters during inspiration and 42.5 centimeters during expiration. Spinoscapular distance on right side was 8 centimeter and left side was 8.5 centimeter. And spinoacromial distance on right side was 19.5 centimeter and on left side 20 centimeters.
So there is a discrepancy, in the
Slide. Yes.
there on the right side, the right hemithorax measurement is less, and the
Slide.
spinal distance is also less.
Slide less.
But there was no drooping of shoulder.
So there was not a drooping of shoulder and
Trachea also was central.
yes, sir, that is central, sir.
Okay, but here's definitely there's a smaller right
Slide.
hemithorax and
Slide. Yes, sir.
spinoscapular distance. Okay, okay, fine. No, because this AP ratio, AP to transverse ratio also,
It
that
is
is
a bit, yes.
suggestive of like a flat chest, 2:1, no, almost
Yes,
0.5.
sir.
So a flat chest you expect in fibrotic lung disease, both of course bilateral, but here unilateral right side there seems to be a slight discrepancy. Anyway,
Slide.
we'll keep that in mind and proceed.
Tactile vocal fremitus on palpation was was felt in every area and was slightly more in right infrascapular area on right side. Percussion, resonant note was felt in every area except right infraaxillary and infrascapular area where a dull note was felt, and chronicus isthmus strobiscus, they were all resonant, and there was tidal percussion was seen in fifth intercostal space. On auscultation, we could hear a polyphonic wheeze in every area, except that in right infraaxillary and right infrascapular area. And in addition to polyphonic wheeze, we could also hear early to mid inspiratory creps. In vocal resonance, sir, it was normal almost in all areas, slightly increased in infraaxillary and infrascapular area on right side. However, I could not uh, 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 I could not hear whispering pectorality or egophony clearly, sir. So I am not mentioned them. Other systems, she was not elevated. Uh, Abdomen, there was also
Hold on. Before we move to the diagnosis, a good habit is to the intensity, the type of any added sneezing or creps also in certain. What would you expect? What kind of breath sounds would you expect if there is consolidation?
usually in a patient who has an underlying consolidation, there may be mid to early to mid inspiratory crepitations.
That's true,
Okay,
but that is an adventitious sound. So
intensity of
crepitation.
slightly increased, and there will be yes,
So intensity of breath sounds is fine,
yes,
but what type of breath sound you expect in a consolidation is tubular
bronchial.
bronchial.
So there will be bronchial breath sounds. There will be prolongation of inspiration and expiratory phase. Will not be characteristic of those normal vesicular breath sounds, where the
Correct.
expiratory phase will be increased once there is consolidation.
Correct. So in any bronchial breath sound, the audible expiratory phase is longed or prolonged,
Yes, sir.
and there's a gap between the audible
Inspiratory
expiratory
and
and audible expiratory phase. But if you're thinking of consolidation so far, there is a doubt because of the increase in vocal resonance, diminished respiratory movement, even crepitations here. So in any case, whether it's there or not, you should always have this habit of first commenting on the intensity of breath sound followed by the type of breath sound. So intensity of breath sound, normal, reduced, increased, type of breath sound, vesicular breath sound, bronchial breath sound. If you're thinking bronchial breath sound, tubular, what are the subtypes of bronchial breath sounds?
First of all, we have normal vesicular breath sounds where there is inspiratory and expiratory. There is the expiratory phase of the breath sound in normal vesicular is 1/3 of what is inspiratory, and there is no auscultatory gaps between them. Then we have bronchial breath sounds where inspiratory phase and expiratory phase are equal, and there is a normal expiratory gap between them. Then, sir, we can have this amphoric or tubular breath sounds in case of cavitations and cavities in lung. Then
Correct.
we have, sir, we can have added breath sounds. We generally classify them into broadly two categories. One is V's and second is crepitations. Sir, they are further divided into subdivided into different categories. Like in crepitations, we have early to mid inspiratory crepitations, like we have in this patient. They are found in usually these patients who have consolidation, underlying consolidation. And then we have mid to end inspiratory crepitations. They can be mid inspiratory crepitations are usually seen in patients of heart failure. Not then and in crepitation and inspiratory crepitation is giving a velcro, like they are usually found in patients who have underlying ILD. So,
Correct. Correct. So usually early inspiratory crepitations are heard in chronic bronchitis. Mid
yes, sir.
inspiratory is in bronchiectasis. End inspiratory is in heart failure as well as interstitial lung disease
Yes, sir.
and lung
And
fibrosis. I'm
and
sorry.
then, sir, we can compare them based on gravitational, sir, whether they are gravitational dependent or not.
Correct. Sorry. So what I wanted to ask you was what are the subtypes of bronchial breath sounds? So bronchial breath sounds can be tubular, amphoric, or cavernous, as you correctly said. Tubular is what you expect in consolidation, and amphoric is where there is a metallic quality to it, and it's heard in bronchopleural fistulae. And cavernous, like you correctly said, is heard over a superficial cavity. These are all the amphoric and cavernous tubular breath sounds are low pitched breath sounds, whereas tubular bronchial breath sound is a high pitched breath sound. So always have this habit when you're presenting the auscultation part in respiratory system. Start with intensity of breath sound, type of breath sound,
Okay.
then move on to the adventitious sound. Another
So,
adventitious sound is pleural rub. So if it's a not a lung parenchyma disease, it might be a pleural pathology. That also you can comment on if it is there or if it is not there. One more thing is generally as a dictum in respiratory system, we include the upper respiratory tract in the respiratory system format or the proforma, because you have mentioned oral cavity in the general physical examination, but the nose, the paranasal
yes, sir.
sinuses, the oral cavity, the pharynx, these also, including the larynx also, these also are important. Of course, larynx, it's not easy for us without a laryngoscope to examine, but these give us certain clues. So, can you tell upper respiratory tract how it is relevant with regards to lower respiratory tract pathologies?
Sir, during this upper respiratory tract, sir, it can be involved in any kind of bronchial infection, and just like you said that we have to. I had initially, I don't know how it got deleted. I had kept that thing,
No
sir.
problem. No problem.
Yes, sir.
No, it
So
depends. See, certain examiners may prefer it in other different ways,
yes,
but
sir.
generally most will, or even if you mention it in general physical examination, you again mention it in respiratory system, because most old time examiners will
Yes, sir.
explain it. In the respiratory
So
system, you will first talk about upper respiratory, then move on to lower respiratory tract. It's okay.
sir, just like this patient, she is a female patient who is in her fourth decade or fourth to five decade. If this patient would have presented to us with hemopsis like presentation, then we would have suspected GPA, and then we upper respiratory tract, in upper respiratory tract we had to inspect her nose and nasal bridge, perforation of nose crusting,
Very
and
good.
in
Very good.
sir,
Correct.
sir, other things like we have any patient who has a posterior pharyngeal wall involvement, we will have to check that posterior pharyngeal wall hyperemia may point to pharyngitis, sir, or stridor can be present in laryngitis, which could be a part of upper respiratory tract infections, and then
Correct. Very true. So
then
even,
these.
for example, H1N1 influenza, very prominent symptom. The throat pain in influenza, especially H1N1, the throat pain will be a very prominent symptom. So they will have some amount of pharyngeal congestion, which you can notice,
Yes,
especially if
sir.
you're thinking of atypical pneumonia.
Sometimes they can just give us the history of odynophagia, and then we have to extract other things.
Correct. So let us say you're thinking of bronchiectasis, not in this patient, but in general. If you're thinking of bronchiectasis, how would upper respiratory tract examination be important?
So, in bronchiectatic patients, the first thing is that usually bronchiectasis is a disease of old age, and those patients, the repeated aspiration is part of that.
Okay.
So we can, in upper respiratory tract, we can check. We can even check their oral hygiene, sir.
Okay. Now, let me be more direct. Supposing a young patient with recurrent respiratory infections, I am suspecting bronchiectasis. I hear the heart sounds on the right side. Instead of
Yes,
hearing it
sir.
on the left side, I'm hearing it on the right side. Now, what clue will I look for
Sir,
in the
it could be Cartagena syndrome, situs inversus, and there may be productive sputum in those patients,
correct
and there
upper
will be
respiratory?
upper respiratory. Sir, oh,
Basically, the same thing. So, cilia is not moving. That's why there's bronchiectasis in the lung. So, what should happen?
sir, nasal block,
Mm,
mucus,
Mainly the paranasal sinuses. So, they'll have recurrent
sinusitis,
sinusitis,
recurrence.
and sinusitis. Nose also, yes, but recurrent sinusitis. So, sinus tenderness, paranasal sinus.
Yes, sir.
tenderness. That also gives you some certain clues. Okay, so supposing like this lady that has no history of wheezing in the past, no history of atopy in the past, or even in the family, you have taken that history also, family history. So now she's presenting with wheezing. Let us say she's not having she's not having fever. Let us say fever is
Okay.
over. So it becomes like a non-atopic asthma, correct?
Yes, sir.
Non-atopic asthma, what upper respiratory pathology would you want to look for? Is there a relationship between upper respiratory tract pathology and non-atopic asthma or adult onset asthma? There's a frequent association of nasal polyps. So
Yes.
nasal polyps with non-atopic or adult onset asthma, especially if there is also something called aspirin hypersensitivity. So these three are known as Samter's triad.
Symptoms, right, sir? But
Samter's triad. Yeah.
sir, is it is the age of patient like that? Can it
Yeah.
present in this age also?
Adult onset, yeah, it's non-atopic, so it's
Okay.
not nothing to do with atopy.
Okay, sir.
That's why they can present at this age. So this is what you would suspect. Of course, this is the first time she's had. It's all in all likelihood it's an infection that's triggering her wheeze. But if
Yes.
these episodes were recurrent, that
Okay.
also you would have kept in mind. But that this is just to highlight that upper respiratory tract is also very important
Important. Very important.
in terms of respiratory system, especially lower respiratory tract pathologies. So make it a habit, present upper respiratory tract even in the respiratory system format itself.
Okay. Yes.
Okay, so beyond that, your examination presentation looks fine. Of course, general physical examination, nothing much, except for the fact that she is requiring oxygen. She is on oxygen.
Yes, sir.
So since she is being supplemented oxygen through the nasal prongs, you are not seeing any signs of respiratory distress, no
Yes, sir.
accessory muscle usage. You have
Yes.
mentioned Alanacei, sternocleidomastoid, they're not in use. That's because she's getting the oxygen. And respiratory rate, did you mention? That was one
Yes,
thing
sir.
to
Yes.
ask. How much was the respiratory rate?
Sir, it was normal 18.
18. Okay, yeah. So that again, because, yeah, I saw it. That again, because she's receiving oxygen supplementation. So that could also be because of the fact that she's receiving,
Oxygen.
yeah, oxygen. So that's why we are not getting any examination findings of distress. But pathology wise, she does seem to have creps on the right infra and infrascapular and infraaxillary areas. So the pathology probably lies somewhere there. Okay, so what now you tell me what diagnosis will you think of at the end of history and examination?
Most likely, sir, this is uh, infective pathology. Most likely, community acquired pneumonia can be suspected.
Okay, so community acquired, probably
Pneumonia,
atypical pneumonia.
atypical.
So it's not looking like a consolidation.
It is not looking 100%
Yeah,
consolidation because there is not a conclusive history and examination findings that could
correct.
corroborate
No,
the same.
no productive cough, no tubular
Yes, sir.
bronchial breath sounds. So you can't put it down to a typical pneumonia with consolidation. It could still be an atypical
No,
pneumonia.
no.
So you mentioned bronchophony and egophony. Can you tell us what are those terms?
Usually, egophony we usually elicit in patients where we suspect consolidation. Then we ask them to vocalize A, and then we subsequently put our stetho in different regions of the chest auscultatory regions. Then wherever we feel that A is not like A seems to be like E, sorry, we ask them to say E, and then it becomes like a like bleating sound. Then that is known as actually egophony, and this is just to corroborate our suspicion of this consolidation. Then bronchophony is again similar to it, and if we some patients we can even elicit whispering pectoral leaky where the patient even whispers and we could hear clearly on the other side.
Correct. So these are qualitative and quantitative differences in vocal resonance. Bronchophony is quantitative, where bronchophony and whispering pectoral leaky are quantitative. Whereas egophony is qualitative, where you ask the patient to say E, but it comes out as like that when you're hearing it. And these could be found in consolidation, and egophony can also be found in egophony can also be found in pleural effusion at the level of pleural
at the
effusion when
level.
you're auscultating. Okay, correct. So right now you're thinking of an atypical pneumonia. Any other differentials you'd like to give?
So it could be a hyperreactive airway disease that has presented as an index event and has been precipitated by this LRTI right now that patient might be having, because
Yeah, I mean,
but that is less likely, sir, than
you're still considering the LRTI, no? You're still considering that.
yes, sir. LRTI is still
So if pneumonia itself can explain everything, you don't need
yes,
to bring in anything else
yes.
unless you there was a history like repeated wheezing, repeated
No, sir.
episodes where
No,
she
sir.
used to have breathlessness or atopy, then or she had history of using inhalers, then you could have brought that in. Right now, you wouldn't need to bring it in because everything is explained just with the pneumonia part itself or the LRTI part, lower respiratory tract infection. Anything else? Good enough. Good enough. So one more reason why a pneumonia can persist for so long, I mean, probably her breathlessness, progressing to breathlessness at rest, would have been 1 or 2 days before her arrival to the hospital. Because if it was earlier, she would have come in earlier. One can't remain breathless at rest and still survive for
Yes,
more than, let's say, a couple of days. They would have to be rushed.
yes, sir.
So probably that has happened little towards the end of this period of 9 to 10 days. One more possibility is what happens is if there is a viral pneumonia, this viral pneumonia will get a super added bacterial infection.
Infection, exactly.
So that may be the reason why it's prolonged. So the initial 4 5 days it would have been just the viral pneumonia, and then that led to maybe a staphylococcal. Sometimes viral pneumonia gets super added or super infected with staphylococcal or streptococcal pneumonia, and that can worsen things. So if there was a fever, there would have been a respike. There would have been a dip in temperatures, and then again it would have spiked up. So that would have given you a clue or would have made you suspect that yes, this is a secondary infection, secondary bacterial infection of a primary viral pneumonia. But still, is this kind of a history, you have to think of pneumonia only. Would you think of tuberculosis, pulmonary tuberculosis for this lady?
Sir, one thing that points to that there is one suspicion, but it is refuted by a large portion of things that we discussed currently. One thing is that there is no history of, sir, weight loss. There is no chronic history, and
That you can't have. I mean, 9 to 10 days history, there's not going to be much weight loss. So,
sir, the fever itself, she didn't give a history of prolonged fever or uh,
correct,
profuse night sweats and the
correct,
things that we usually see. Maybe that it is present, but I think it could be less likely.
correct.
But
Typical
since
pneumonia, you
she
expect.
but since she is from an endemic area, we can keep that thing in mind.
Correct. So typical pneumonia, you would expect a shorter history. Tuberculosis, you would expect a slightly longer history. This is
Right.
coming in between. So not easy to make out. But non-productive cough goes against pulmonary
Tubal.
tuberculosis at
Yes,
least.
sir.
Yeah, you might think of pleural tuberculosis, but the fact that vocal resonance is increased, if it was decreased with the
Yes,
dullness, then dullness on percussion, then you would have thought of maybe a pleural effusion. But here the vocal resonance is increased,
increased.
so which favors maybe some segments of the lung are consolidated, but not an entire lobe.
No, not.
Yeah, so tuberculosis little difficult. But otherwise, 9 to 10 day history, you may not get the typical weight loss history because it's not yet long enough to lose weight. Yeah, so tuberculosis not the most likely cause. Okay, so how would you want to proceed with in terms of investigations, workup?
So I would like to do, sir, X-ray and CBC of the patient first off, because both of these investigations are important at baseline level, and then after that we can then grade the patient on the basis of the severity of his her symptoms. Like, she seems to be a candidate for in hospitalization, we could treat it by admitting the patient and treat it as non-severe pneumonia, sir.
Okay. I don't know if the use of non-severe would be appropriate. She's requiring 3 liters
So,
of oxygen. So, correct. Admission is definitely warranted because she's requiring oxygen. X-ray, what would you look for? What features would you want to see or check?
so I would like to see, sir, consolidation usually
Okay,
because
how is it described? How will you describe a consolidation on a chest X-ray?
so, there will be in like in this patient there will be the cardiac silhouette on right side that
Correct.
might be obliterated, sir.
Correct. Okay, good.
So then there will be
Really, right side would be difficult to get the silhouette sign. Left side would I would have agreed.
then there will be this
So you generally describe it as a homogeneous opacity with air
an
bronchograms.
air bronchogram, sir.
That
Yes,
is
sir.
consolidation.
Yes,
Because the alveolar spaces would be filled with exudates, almost solid exudates, whereas the bronchi and the airways would still be patent. So you can
patent
make them out on a chest X-ray as lucencies, which are called air bronchograms. Correct. Otherwise, atypical pneumonia, you would get a more interstitial pattern.
pattern.
So interstitial pattern is described as a reticular pattern or a linear to reticular pattern. Not so much nodules. Sometimes you might get nodular also. So reticular nodular opacities
Yes,
might get on an interstitial pneumonia. Um, would you suspect this patient to have pneumocystis pneumonia? Pneumocystis jirovecii. Would you?
sir. I don't think so, sir.
Okay. Why not? Because see, dry cough, atypical presentation, breathlessness despite you're not getting extensive lung involvement in on examination, only the right infraaxillary infrascapular, some
Sir,
restriction of movements.
sir,
Beyond that,
usually pneumocystis pneumonia or pneumocystis jirovecii pneumonia, we have patient most likely looks to be immunocompetent, sir. This
this lady seems to be immunocompetent, you mean.
yes,
So no signs, no history nor examination findings of immunocompromised status.
yes, sir.
So nor is she diabetic, uncontrolled diabetic, nor does she have risk factors for
No,
HIV infection,
yes,
nor is she taking over-the-counter steroid medication
nothing like
or
that. So
medications for other
yes,
immunological disorders. Examination wise, also BMI was quite decent,
yes, sir.
22.5, and no markers of malnutrition. So
Yes,
unlikely that it is PCP because these are certain differentials. If you get a patient who is breathless, who is hypoxic, and still you don't get too many test findings, pulmonary embolism is one differential.
yes,
The other is PCP pneumonia. PCP pneumonia, the signs will be limited, but the patient will be very breathless. So because of its predominant interstitial, it's not pure interstitial. There is alveolar involvement in PCP, but interstitial predominant involvement will produce very minimal examination findings, but patient will be hypoxic. And one more thing you should always rule out when a patient seems to be tachypneic, but the chest, there's no signs, is severe metabolic acidosis. So these are some of the findings
yes, sir.
or some of the reasons why a patient may appear to be tachypneic or breathless and even be hypoxic. Of course, metabolic acidosis, they'll not be hypoxic, but pulmonary embolism, PCP, and metabolic acidosis, some causes where signs are less, but patient seems to be tachypneic. Okay,
So
so
ABP, sir, could it this patient have ABPA?
allergic bronchopulmonary aspergillosis. The history is too short.
Okay, sir.
ABPA, the history will be longer. I mean, the patient should have asthma, should have been
Okay,
labeled as asthma.
okay,
So it doesn't happen in an acute setting.
okay,
Again,
sir.
if aspergillosis has to produce acute breathlessness, it must have to be invasive aspergillosis,
Asthma. Okay, sir.
which again requires 45-year-old without comorbidities, unlikely.
Less likely.
Older patient, maybe with intake of steroids or immunosuppressive drugs, that you could have suspected.
Okay, sir.
9-day history for ABPA, unlikely for such an acute presentation, first time. So she needs to be treated. So if she's not responding, then you think of
Okay.
ABPA when there's a like a refractory or difficult to treat asthma.
So there should be a history of asthma per se
There
background.
should be a previous
Yes, sir.
history of asthma, meaning like it's a continuing history of asthma, which is not responding to treatment. That is when it strikes, ABPA strikes.
Okay.
Otherwise, such a short history is unlikely to be ABPA. Yeah. So again, CBC, what would you look for in CBC?
Look for leukocytosis, sir.
But if it is atypical,
So usually atypical may have normal TLC with there may be a lymphocyte predomination. There will not be characteristic neutrophilic predominance in this.
correct. So you might
The,
get a leukopenia also, especially viral pneumonias, you get leukopenia.
yes, sir.
Or you might get a normal leukocyte count. If it's elevated, you think of a typical bacterial pneumonia.
Pneumonia. Yes, sir.
So if she is not producing sputum and you still want to start, how do you want to manage this patient?
So, we will have to first take care of her symptoms and at the same time uh, correct the underlying. So like in this patient, we'll start with oxygen inhalation. Then we will correct her fever. We will give antibiotics like we did in this patient, and then antibiotics subsequently. Usually, any patient who gets admitted where we suspect a patient to have pneumonia of any kind, usually we should have a local this protocol.
Antibiogram.
Yeah, antibiogram exactly, sir. But since in our setting it is not present, usually we start with broad spectrum antibiotics in this patient.
Okay.
But since this patient does not have any previous history of hospitalization or any IV drug intake significant, then
Hmm.
we can skip this um, uh, anti-pseudomonal cover or other things. We can just give this patient antibiotics, broad spectrum like cephalosporins and
So if it is some organism which doesn't have a cell wall, which cephalosporin will work only by inhibiting the cell wall synthesis. So you want to cover atypical organism. What agent would be preferable?
sir, we can do doxycycline.
Doxycycline is a fair enough choice, just that it's a drug.
As it azithromycin.
Correct, azithromycin. So doxycycline, because though it's a tetracycline, it has more bactericidal than
Azithromycin,
polycycline.
sir, we will give azithromycin because
Yeah,
it is also included in Harrison. Just
correct. No,
remember.
azithromycin is a sidal drug. It is
Yes,
definitely going to be a
yes,
more aggressive antibacterial agent than doxycycline, which is slightly slower, more static.
yes, sir.
So you want to cover for atypical
Yes,
organisms.
sir.
And still, if you want, let's say in an ideal scenario, I can understand in your setting it's not available or maybe resources are limited. But if in an ideal scenario you want to find out what organism is causing this pneumonia, what would you do? She's not
So,
producing cough. I mean, she's not producing sputum. What can you do?
so we can induce sputum in this patient.
Good, okay, but still
We,
it's not coming. You tried inducing, you gave hypertonic saline nebulization or N-acetylcysteine nebulization, still not coming out. What can you do? You're
sir, if usually we don't do, but we if it is so important, we can give mini bronchoalveolar lavage.
correct, correct. So bronchoalveolar lavage. If you want to really diagnose this patient,
Yes,
and
sir.
let's say facilities are available, patient is affordable, setup is present, then the best thing to do is do a bronchoalveolar lavage, get to the root of the problem, find out what bacterium it is, and if possible, culture it and aim for the bacterium with the appropriate antibiotic. Okay, so good, Shamshul. Presented well.
Thank you,
History and
sir.
examination. Management also, of course, you have to keep in mind about questions on management. Otherwise, you did a good job. Good job with
Thank
the
you, sir.
history and the
Thank you,
exam.
sir. Thank you, sir.
Yeah. When are your exams?
Sir, exams are coming, so
Coming when?
I,
Couple of
sir,
months.
I have sent up schedule to be held in 22 of this month only, so I wanted to present this case
Okay.
first up.
Good. Good. Study hard.
Thank you, sir.
All, all the best. All the best for your
Thank
exam.
you so much. Thank you so much. Learned a lot today.
Yeah, yeah. It's a two-way learning. Even I learned a
Yes,
lot.
sir. Thank you
Take
so
care.
much, sir. Okay.
Take
Good
care.
night.
Bye.
Thank you. Take care, sir.